Scaring an alcoholic with life.
I think this sort of artificial bottom creating that a lot of people have been talking about, or lowering one's bottom, is the problem with that concept is it's not real for people.
Right.
Well, I do believe that most people do stop drinking or stop using drugs because they're afraid they're going to lose something.
Which could include themselves.
It could be death, yeah. You know, some people have a seizure from using crystal meth and they realize, oh, you know, maybe I'm going to die. Or some people even have strokes from, you know, smoking crack and their arm doesn't work anymore. And they're like, oh, you know, maybe I should stop. You know, sometimes it takes that much. Some people get in a DWI accident and they kill themselves or kill someone else or someone in the car with them. That's enough of a bottom. But often, you know, bottoms are different for different people, and we don't really know what they are. And then once people stop drinking, it's very easy to forget where your bottom is. And part of CBT, I think, is reminding people of the consequences of drinking.
But a big part of it, and this is to Judah's point, is long-term thinking versus short-term thinking.
Correct.
And in an addict brain...
That impulsivity.
Yeah, I'm not going to get all medical, but the hippocampal limbic connection, which is the emotional memory connection, is tied into actually doing the drug. So you have more short-term impulsivity in regards to memory imprinting over long-term. So if you're an alcoholic and I'm like, hey, guess what, man? If you keep drinking when you're like 58, your liver's going to be fried. Let me tell you. You're like, whatever.
Yeah.
But if I tell you, you know, in 2 days you're gonna like be vomiting all over the place and your girlfriend's gonna leave you and your dog's gonna die and all sorts of other stuff's gonna happen, you might actually pay more attention to it.
Right.
So, you know,
and might, which is funny that you say might.
I said might.
Because that's my favorite question in the big book of, you know, in the Alcoholics Anonymous book.
Yeah.
It says the spiritual life or an alcoholic death is not always an easy question. And it's basically saying die in a pool of my own urine or to live a happy life is not an easy question for alcoholics.
Yeah.
I've done a lot of work with CBT, cognitive behavioral therapy, and dialectical behavioral therapy, but mostly for anxiety disorders.
Yeah.
Which I think they work. There's a more immediate return there. You know, I think we're seeing at our treatment center that we're using more psychoanalytic techniques more and more. As we tend to get longer lengths of stay with clients.
The DBT thing's great too. You know, I run an intensive outpatient program.
You just opened that, didn't you?
Yeah, the Control Center. It's been open a year.
It's a great name.
The Control Center for Addictions. It's in Beverly Hills, and we integrate spiritual therapy, dietary treatment with neuroscience and psychoanalytical work. So it's like taking, because I lived in this academic bubble for a long time during my training, and I think you'd appreciate this. In the academic world, it's like most of the residents don't even know what the steps are.
Right.
Seriously,
right.
They don't know step 4 from 9. They have no idea, but they know about, you know, what Chantix does. They know what Prozac is.
They have a rep coming around telling them.
Yeah, let me tell you the things about the reps too. Just on
sales reps were
get them early.
Just on a side note, the whole world of pharma has changed a lot. You know, I dig pharma. I get the fact that meds are important and all that, but the way that marketing works, they've really regulated pharma, because at one time they would bring in like the most attractive women ever to a bunch of geeky doctors
with bags of pills,
with bags of goods and like short skirts, right? And we're geeky doctors. Like most doctors that have been through 15 years are like, oh my god, a girl, oh my god, she's gonna talk. Do you want to learn about Prozac? Sure, okay, whatever you say. Like they'll just do whatever they say.
Yeah, and then he had like old crotchety men coming in to teach you about AA.
Yeah,
isn't that great? You show up with chronic major depression, and the drug you get is based on how short the girl's skirt was. Is that really what we've become?
That's not exactly true, but okay. This was a big debate that a lot of universities had, which is, okay, if somebody who's a rep tells me, hey, my drug is better than this drug, right? I know more than that rep knows generally. So maybe it's a super rep. I don't know. But generally, the doctor's going to know more than the rep. So you're like, yeah, whatever. Okay, that's great. Give me my pen. You know?
We're going to take a quick break. It's KLEAN Radio. You can call us.
And the number here is 877-8-830-830. That's 877-8-830-830. You're listening to KLEAN Radio.
We got Dr. Reef Karim taking calls. Talk to you soon.
Shaking to the top. The shaking tone is Cadillac.
Now back to KLEAN Radio.
The Sober Lifestyle Show, presented by KLEAN Residential Treatment Center.
On Angels Radio, AM 830.
One day, Judah, I'm gonna have to get you to stop doing that.
It's My Chemical Romance.
This dance you do.
I love My Chemical Romance.
Can I just say, as an outsider, that was kind of weird.
Yeah,
It's weird, right?
I just want to say, it kind of scared me.
I get into the
And
music,
the fact that it's filmed and people can see it on the internet
and that I don't care.
on KLEANradio.com.
You know, it was almost like he was having an orgasm. Like, not that I know what he looks like when he has an orgasm.
now to your other area of expertise.
What I like is that the
segue.
psychiatrist is the most inappropriate person here. That's
usually the way it
it's
is.
refreshing.
I will tell you this. It is true. I will tell you the scariest thing when I was going to check out psychiatrists and.
Like psychiatrist.com.
Yes,
Wouldn't that be great? They had all the pictures, like, and all the kind of weird eccentricities they have.
right. That would be a great idea.
Yeah.
And it'd be
a book of pathology.
it would be very helpful.
Right.
But I went there and I was at
Stutters.
Cedars,
There's
and
a lot of blood.
they had one of the drugs on the door. It was like a label, when you walked in. It was like Lanestra or what? It was one of these.
Lanestra?
They
Yeah.
had like one of these companies like put the
Really? They
sticker
put
on
the
the
big
door,
thing, the big-
and I was like, this can't be good. Like when you're walking out of this psychiatrist's office, you're committing to being on. The second you walk in, you're like, okay, drug me.
Yeah.
And for me, it actually really freaked me out. But I want to talk about a fear that a lot of people have. A friend of mine actually has this fear, and it's really my friend.
Yeah.
It's not me it's my friend.
Yeah, sure, whatever.
A lot of people's biggest fear with meds is that you constantly hear them say, it's going to change me. Which is really funny because, they feel like it's going to do something to them or it's going to make them different.
Right.
But they're referring to like it's going to somehow make them slower or it's going to not. But they're not being fully, they're not using their full capacity yet. But it's a funny fear.
Yeah, so there was a recent study that came out that I thought was really cool, where we always talk about medications, especially antidepressants, being symptom reducers. When these medications first came out, it was like, Prozac Nation, right? Everybody was going to be on this medication. They were happy pills. They were going to suddenly make everybody not depressed and happy, and the world was
Soma from 1984,
Right.
Like the
the world was going to be a better place. We were all going to love
medication.
peace and love. It was going to be like a new 60s, revolution. And then we found out that they didn't quite deliver to the way we wanted them to. They're still good.
And they affect different people differently.
Yeah, there's variability in how in absorption, but they generally reduce symptoms. So for depression, you've got a depressed mood a lot of the day, anhedonia, things that you normally find pleasurable you don't find pleasurable anymore, feelings of hopelessness, helplessness, worthlessness, fatigue, anxiety, all that stuff. It gets better because it's a symptom reducer. But there's a study that came out recently that said, hey, it not only reduces symptoms, it increases neurogenesis. So the actual production of neurons and then how they connect is actually better and enhanced by antidepressants. So you're actually having structural and functional changes, not just based on symptom reduction. So
And that's very new because for a long time we believed the brain decreased over time, the amount of cells that it had, and didn't really restructure, reorganize, or rarely. And so, I know there's another study that said the same thing with exercise. Exercise is one of the best things you can do to actually rebuild neural pathways. And
there's look, we're going research back.
Yes,
and forth.
I know. This is fascinating.
Well, how about this one? Well, let me go with this one. So there's another study that looked at an antidepressant versus exercise, and they were even.
yeah.
So for all
do
of you,
both.
If you
Run to your drugstore.
Yeah, so if you go to the drugstore, do it fast. If you actually exercise 3 times a week, in this study at least, it's like taking an antidepressant. It's just we're a pill popping society. We love to pop pills. We pop pills to do everything. So who wants to work out 3 times a week when you can pop a pill?
I know, not Andrew.
That was rough.
I've been getting my chops busted the whole time. That was one little dig.
God.
And I have been on an exercise break, I do admit. So I'm guilty as charged.
That was no, but I do think a lot of people. It's funny. I think a lot of people do have some I had that fear. That was a huge fear of mine. Was like somehow I'm going to take these meds and I'm not going to be as creative.
Acyclovir? The herpes medication?
Yes. I thought the herpes medicine had a different name. Valtrex.
Yeah, Valtrex.
Not that I know. And
He can't talk right now. I just
he names it, and then he's like, I don't.
well, everybody knows what everybody.
It's because of the horse commercial. That woman that gets on the horse, and suddenly it's like, take Valtrex, and she's riding the horse like it's like this wonderful experience. That was weird.
I actually haven't seen that commercial. That might be one that was just released to psychiatrists.
Reef has it on loop on his screensaver.
But I think it's a lot of people's weird. It's you know, I want to talk about something we were talking about last week that and it's a huge issue now with this. You know, there was a famous actress that just with bipolar disorder. And for years, I've been saying, you know, I've noticed a lot of people that do have bipolar stop taking their medicine. You know, there is an IUD, right? What do women take? You know, to IUD, right, to prevent that automatically disperses.
What are you talking about?
Drugs into your system.
IUD
so you
is actually an insertable.
Right, so that
device.
it drop something.
No, it actually just agitates the uterus. So
Okay, so wouldn't it be great if there was something? Is there anything that like?
How did he make that transition? I'm still like,
Right,
he
why
went from bipolar disorder to an IUD.
No, because
I was
maybe
like,
maybe we're doing
because
Love Line. Maybe we're on the wrong show.
because when you do have that because then you
I've
don't,
never heard that before.
because you never forget to take a pill. So
yeah, you're talking about the estrogen implant.
Is there anything like that with bipolar meds that somebody could have it inside that it automatically
like a bipolar implant?
like a bipolar implant? Because that would be great, because it's sad because people, you know, we had a caller last week with his daughter that stopped taking her meds.
Well, like we talk about a lot on the show, medication compliance is the #1 problem with the mentally ill.
Right,
Especially bipolar disorder.
Is there anything on the horizon? I mean,
There's been a lot of different attempts, nothing very successful. There's been longer term shots, right?
Yeah, I was just going to say, you totally hit it, Andrew. That's the main thing we use. So if somebody comes to a psych facility, like, you know, they come to the psych ward, the first thing we're going to do is check out their compliance.
Right.
If we think they have really good social support, family support, spousal support, we'll put them on a pill. If we feel like, I don't know, they need to get meds in easier, we'll give them a liquid. If we're just like, okay, there's no way this person's not taking any meds the minute that they leave here, we know it, we'll put them on like a 2-week shot. And, you know, they have shots where you can take every day. They have shots that'll last 2 weeks.
I didn't know this. That's
So and then, you know, if you can get them, you can kind of do a monthly shot, but, you know, they wear off a little bit. But the thing is you can actually, the family has to force them into their doctor's appointment every 2 weeks instead of like every day where they don't take their pills. So
fascinating.
But they've been looking into other ways. I mean, the one thing that's nice is now a lot of these medications have also become dissolvables.
Right.
Which has made a huge difference because they're easier to dispense. You don't need a needle, obviously. They're not intramuscular. So, and that's made a big difference for a lot of outpatient treatment, is we've seen things move towards outpatient settings and away from, you know, clinical acute care, lockdown psychiatric settings.
But I think what's also interesting that we're talking about this is that I didn't know that there, you know, you guys, both of you seem to be a doctor that is actually in tune with his patients. That's the scary thing these days, is how many psychiatrists aren't in tune with their patients, and how many psychiatrists meet you one time and say, you know, you need to be on something.
Right. Well, I think, I don't know, you know, like CSI guys, you know, like you have to know the criminal to be able to kind of figure out the crime scene. You know, like from TV, you kind of watch it. I think a good psychiatrist has either lived. I don't think you need to be schizophrenic to treat schizophrenics.
Right.
But
I hope not.
You know, but I do think you need to have lived enough to know when you're being played. Because I can't tell you the number of patients that'll come into my office, and probably my colleagues' offices, and they're like, Doc, you know, I got ADD. I know I do. Like, I can't focus right now. Where are my keys? Oh my God, I can't find them. And like, it's like they looked online, they Googled ADD, they memorized 5 things, they come into my office, and they like name all 5 of them and ask me for meds.
They ask you for Adderall.
Yeah, exactly. That's
Preferably crushed. Preferably crushed.
Yeah, preferably crushed, ready to snort.
Dexedrine, Adderall, I'll take any of them. Vyvanse if you crush. You know, they know. Here's the thing. Here's the key thing for any doctors listening, or any family members. If your patient knows more about meds than you do, they're med seeking.
Right.
That's like the number one rule. You know what I'm saying?
The other thing that I think is just, you know, we had Dr. Coe on the other day, who's another psychiatrist that works at KLEAN, and we were talking about how, unfortunately, the field of psychiatry has largely become largely prescription writing. The psychopharmacological element of psychiatry has become the dominant sort of form of the industry, largely forced, unfortunately, by reimbursement sources, insurance, and other outside forces, not really so much psychiatry itself. Because most psychiatrists that I talk to on a regular basis and that I work with, they would like to be doing more work with clients. And the truth of the matter is that psychopharmacology is still relatively young. I mean,